Hi, thank you so much for joining us. Welcome. This presentation is made possible by both Florida Atlantic University Center for Autism and Related Disabilities, as well as PEPSA, which is our partnership for effective programs for students with autism. Just to start off, we want to share a little background about FAU CARD, who we are as an organization. So first, our mission for FAU Center for Autism and Related Disabilities, we provide expert consulting, training, and support at no charge for all people across all race, ethnic, and gender groups with autism and related disabilities, their families, employers, the professionals, and community and governmental agencies serving them. Our vision, FAU CARD provides support and assistance with the goal of optimizing the potential of all people across all race, ethnic, and gender groups with autism and related disabilities. We have a 5-county catchment area, so our southernmost point is Palm Beach County, and then we extend northwards up through Martin, St. Lucie, Okeechobee, and Indian River counties. We have 3 offices, the first being at the FAU campus in Boca, the second being at the FAU campus in Jupiter, and the third being in Port St. Lucie. Here are some of the services that we offer at no charge. First being our family and school consultations. We also offer trainings and workshops such as these, and these can be geared to a variety of audiences. It can be both our individuals on the spectrum, our parents, as well as the professionals serving them. We also offer public education, and where we are able to share just information, maybe it be about autism and or related items. We also have referrals and resources to help families and individuals locate needed resources within the community. We offer adult hangout groups and so much more. So to transition, today we are going to be presenting on Behind the Mask, supporting girls and women with ASD and mental health struggles. I am Alexandria, and I am pleased to be here with 2 of my esteemed colleagues. I will go ahead and let Cheryl introduce herself.
Thank you so much, Alexandria. It's really an honor to be here today presenting with my colleagues. My name is Cheryl Checkers. I'm a licensed mental health counselor in private practice, where I specialize in the treatment of individuals with both ASD and comorbid mental health diagnoses. I'm also a clinical consultant for FAU CARD, and I am the president of NAMI Palm Beach County. In addition, I'm a parent of adult daughter on the spectrum. Very happy to be here today, and I'll go ahead and pass it over to Alexandria.
Hello again, I'm Alexandria. I am the iRise2 Mentoring Program Coordinator at FAU CARD. My background is in mental health, so I started off in experimental psychology and then transitioned and got my master's in mental health counseling, and recently became a licensed mental health counselor. And I will toss the reins to Lee.
Hello, thank you. And it's good to be here. My name is Lee Daly. I am a autism consultant at USF CARD in Tampa, and I'm glad to be working together with these 2 wonderful ladies. My background is in special education and clinical social work, and I have had a lot of years in the field, but I find that I'm always learning. So we'll start by talking about terminologies. In this presentation, we're going to refer to individuals diagnosed with autism spectrum disorder as people with ASD, or we may also refer to them as autistic or neurodiverse. But we realize that some self-advocates prefer to refer to themselves using that sort of identity first language. So we respect both approaches. We just want to be respectful of all people. So we're going to cover some of the characteristics of ASD that are present in early childhood, but they may not become fully manifest until social demands exceed the person's capacities. So together, all of these symptoms will limit and impair everyday functioning. ASD is experienced as persistent differences in communication and interpersonal relationships and social interactions across different environments. Social impediments can be anything from feeling uncomfortable in social engagement to becoming exhausted and confused about the unwritten social rules and expectations. Many people with ASD are literal in their thinking and have difficulty understanding the meanings of communication that are sarcastic or vague or joking or symbolic. People with ASD who are able to use language are often very direct and honest, sometimes blunt. Sometimes they might have difficulty adjusting their demeanor to the context of the situation in different social settings. They may not be able to feel comfortable making eye contact, and they may not show many facial expressions. They also may not understand, excuse me, questions or directions, and may need to have their information given in different ways, different modalities like visual, auditory, or even hands-on, or sometimes written. So it can be difficult, for them to go with the flow of communication because sometimes their ways of understanding it are different. We also find that sometimes people will have difficulty discussing emotions or naming the emotions that they're feeling. Speech and language is often delayed early on in life. Some individuals don't use their voice to communicate, or they might have unusual speech patterns or cadence. Some have trouble understanding the importance of tone in communication and the importance of eye contact or facial expression and body language. Some people with ASD will use other means to communicate, like sign language or augmented communication systems or picture exchange communication, something called PECS, to express themselves. Many people are capable of speech, but the conversation isn't always fluid or reciprocal. Another key set of features of ASD are the presence of intensely focused interest. A person might be really interested in specific topics like motors or cartoon characters or Disney musicals or Minecraft, and they may become really fixated or energized by this topic. And they want to do nothing but think and engage in things around this topic to the detriment of other activities sometimes. But it is worthwhile to mention that a person who has a special interest, it's important to think about getting to know more about that so that you can connect with them. It is their happy place, so it can be very useful as a clinician to know about it and to become aware of it more so that you can help this person utilize it in times of stress or struggle. Many people with ASD have unusually high or low sensitivities to environmental factors like sights and sounds and smells, touch and texture, even flavor. They also may have difficulty with interpreting internal sensations like hunger or thirst or headaches or pain. It can be difficult for a person to modulate their sensitivities, like we can't just ignore what they're experiencing. Which can result in a lot of anxiety about that and tension buildup over time because those inabilities to modulate their sensory input or manage it is going to create a lot of stress. It can sometimes result in challenging behavior or elopement. Some people experience a need for more sensory stimulation. They may have an underwhelming sense of stimulation, so they may be sensory seeking, and you might see this come out in different ways of doing repetitive behavior sometimes to put in that stimulation, or it might be that they need to do certain things to self-regulate. And that would be a way to do it, is to put more stimulation in the form of repetitive motion or repetitive verbalizations or utterances. So it's just something you might note that could help them in some ways feel grounded. Predictable routines are usually preferred to random schedules and rapid changes. Surprises aren't always welcome. Even if they're fun and happy surprises, it's a change from what is predictable, so it can be a little bit hard to manage a transition like that. So it may take more time to make transitions, especially rapid ones, and help the person to feel less anxious about it. You also may see, again, like I said, repetitive behaviors can be both verbal, physical, or movements of objects, using objects in a repetitive way. Talking about the thought processes of people with autism, they may also differ from neurotypical processes. There's something called theory of mind, which is a concept that refers to the ability for a person to be able to understand and predict the thoughts of other people or the behaviors and intentions or emotions of other people. It's like being able to put yourself in someone else's shoes. This is not a particular area of strength in many people with ASD. And so sometimes what in fact might happen is that it leads to confusion about the actions of other people because they don't have the ability to understand what people are thinking or even put themselves in that mind frame. So it can be a bit difficult to read the signs of other people based on just the visual gestures or presentation. This slide here shows just a few examples of the various ways that ASD can present. So in one person, like person A, you can see there are certain strengths and certain challenges, and you compare that to person C and it looks extremely different. So when you've met one person, you don't really know what autism is like. You just know what autism is like as that person experiences it. So it's important to know there's a lot of variety, and that's why it's a spectrum. When talking about an individual on the autism spectrum, it's important to note that when we use terms like high functioning or low functioning or mild, moderate, and severe, these are really subjective terms. The expression of the characteristics that might seem moderate or severe to an onlooker could actually be impacted by the environmental stimuli in that setting, or the access to supports and strategies for coping for that person. So it's understanding, that this is a sort of way of thinking that isn't necessarily accurate, especially from the point of view of the person with autism. They may not feel like it's mild. It may feel very severe to them, even though they may be labeled as mild. So we use what the DSM has come up with is a number system to actually describe the level of support that the individual will need given their current expression of characteristics. So level 1 indicates the need for moderate support. Level 2 indicates the need for substantial support, and level 3 requires very substantial support. The amount of people being diagnosed with ASD is increasing. It has been. According to the CDC monitoring network, about 1 in 44 children has been identified with ASD as of 2021. It is the fastest growing developmental disability. Now, for every girl that gets diagnosed, there are 4.2 boys. Girls are diagnosed with ASD an average of 1.5 years later than boys. Why? Why are these numbers so skewed? Well, to begin with, let's orient to females. To be able to understand the differences between girls with ASD and boys with ASD, we need to consider some factors like what are the differences in early childhood development in general? And then differences in early childhood development of girls and boys with ASD. What about differences in transition? Once we go to adolescence, there's a lot of differences between neurodiverse girls and neurotypical girls. And what kind of health and mental health things do they have to face in those settings, in those times of their lives? And we also need to think about how treatment of females with mental health challenges can be conceptualized in the context of autism spectrum disorder. So looking at the early age neurotypical development, differences in development are evident really as early as preschool. Despite the individual variations in life and experience in families and in the environment. So neurotypical girls on average tend to develop language earlier. have a larger vocabulary than neurotypical boys during early childhood. It averages out later on, but early on, girls are developing their talking and language faster. Boys tend to develop more gross motor skills like throwing and jumping and running, while girls tend to develop those fine motor skills like holding pencils and drawing and writing. This could benefit them in the school setting, and actually, they may be more studious because they have that skill. That'll come into play later. On average, girls are toilet trained earlier than boys. Girls generally enter puberty earlier than boys by about a year. And boys tend to be less likely to inhibit their impulses and behaviors than girls during early childhood. Girls will tend to be more accurate at reading nonverbal signs like tone of voice and gestures, which could make them stronger communicators because they can connect feelings and words faster. So when we talk about socialization, this is an impact, that it really plays a large role in how boys and girls are developing and how they are seen and how they are treated. So the assessment of a person's behavior is also impacted by the way that they're socialized. Girls are typically reinforced for being compliant, quiet, adaptive, gentle, nurturing, and cooperative. And when they behave otherwise, they might be labeled behaviorally difficult. But boys who behave in ways that would get girls in trouble sometimes, like being hyperactive or aggressive or unyielding or demanding, they're kind of it's just chalked up. So that's kind of what we expect from boys. But boys who are shy and withdrawn or passive and quiet, they become a greater concern to parents than girls who have the same characteristics. Girls are expected to be able to control their behavior more than boys. So when we look at the ways that we're socialized, then we look at some of the comparing and contrasting of characteristics of what we see in boys and girls with ASD. We can see that boys tend to have more public kind of outward behaviors in terms of their characteristics showing and meltdowns. They may be more loud in public, whereas girls tend to be slightly more subdued or be able to manage their behaviors in public, even though they may have some issues with the situation or they may have upset feelings. They're less likely to act out in that way or have a meltdown in that way. Boys will tend to be more repetitive in their play. They tend to do the same kinds of play over and over, whereas girls might be more broad and have a tendency to be able to shift into different kinds of activities, different kinds of play, less restricted play. Boys, again, in this case, boys will be paying less attention to nonverbal cues, whereas girls will be paying a little bit more attention, able to notice the verbal cues of others or the nonverbal cues, and maybe even respond in like to that. Girls will tend to choose the special interest areas that are more typical, like less obvious than boys who might be more interested in things like schedules or data, transportation, objects. Girls might be more interested in characters like Disney princesses or other things like that. Boys on the spectrum might be more disruptive in order to gain objects, whereas girls might be more disruptive in order to gain attention. For most children on the spectrum, social communication is challenging in early childhood, but for girls, it appears to be less challenging because in general, girls tend to develop that language and that ability to communicate earlier. So it's likely that girls will appear more socially competent in their earlier ages. And so this will have an impact on how they are perceived and whether or not they will have the kinds of services that they're going to need. So going forward to the next one is that most of our knowledge about autism actually comes from studies that were done back in the 30s and 40s involving boys. The criteria for diagnosis of autism is built upon those studies involving boys. And so it is a problem that will cause girls to be overlooked because they do present differently. So doctors who don't see the typical boy-normed ASD characteristics, they might be hesitant to actually diagnose a girl because it's not quite exactly to the T, right? Later diagnosis for girls, of course, means later interventions. And that valuable window of opportunity for developmental interventions early on gets missed. And that's also possibly one of the reasons why. I mean, there's data showing that girls with ASD have higher rates of anxiety and depression than boys with ASD or neurotypical girls. Many girls with ASD, many people with ASD in general can mask or camouflage their characteristics, their ASD repetitive behaviors or social communication difficulties. They pretend in order to blend in at school sometimes. And so it's exhausting. When they come home from school, you might see a very disoriented or dysregulated person because they've had to keep that mask up all day long. So when does masking become a problem? When girls reach adolescence, the pressure to be social is really amped up. There's studies that suggest girls spend a lot more time in relationship-related activities with other girls or boys that are willing, but you know, the boys will tend to spend more time by themselves or playing with, you know, boys doing an activity like ball or video games, whereas girls in same-sex friendships tend to involve more talking about intimate ideas and likes and dislikes, expression of caring, than the relationships of boys. This could also become problematic and difficult for a person who has been able to mask for a long time in terms of just general behaviors, but now we're getting into a deeper area. And when girls display characteristics that are atypical, like social withdrawal, or maybe they don't have those sophisticated friendship skills about being able to, you know, ask really great questions or show facial expressions that indicate empathy, then they may actually tend to experience exclusion or ostracization or bullying even. So to survive in the social environment, many people will actually just cover up their natural tendencies and adopt the behavior of their neurotypical peers. So that's a problem in terms of mental health. Mental health and ASD is a topic of a lot of study, and necessarily so, because given the statistics that we'll be sharing in a little while, it's a dire need to have those supports and to have earlier intervention and earlier identification of needs. So the help is needed way before adolescence. But often it takes longer to identify autism in girls and provide the guidance and support that they could really desperately use. Shana Nichols, who's the clinical director at the Faye J. Linder Center for Autism and Developmental Disabilities, suggests that girls that come close to meeting the autism criteria when they're younger should be reevaluated as they get into adolescence. So we're going to talk a little bit more about mental health and kind of framing that conceptualization of mental health and ASD. And Alex is going to be covering those topics, operationally defining and reviewing the common comorbid characteristics and the areas that ASD and comorbid characteristics may cause issues for teens and adults. And so I'm going to hand it over to Alex, and thank you.
Thank you so much, Lee, for setting the foundation and framework. As Lee mentioned, I want to talk about what do we mean by this term common comorbid conditions. So comorbidity means that more than one disease or condition is present in the same person at the same time. And these can be chronic, it can be long-term conditions. They don't necessarily have to be short-term, although they can be. And a lot of clinicians or professionals in the field may have different terminologies related to this. So instead of referring to them as comorbid conditions, you may also hear coexisting, co-occurring conditions, multimorbidity, or multiple chronic conditions. So you may hear a couple different terminologies, but for the remainder of this presentation, I will be referring to it as common comorbid conditions, or triple Cs for short. So what are some of the prevalence rates with comorbidity? How are we seeing this clinically? Is it rare? Is it frequent? What we are finding is that individuals with ASD often have other common comorbid conditions or other disorders. So it is actually more rare for folks with ASD to not have a common comorbid condition. So what we're finding in terms of research is that about 70% of individuals with ASD actually have one or more comorbid conditions. 41% may have two or more. And breaking them down, we find that 52% of individuals have an anxiety disorder and 40 to 50% have a depressive disorder. And so this is not an all exhaustive list by any means, but these are some of the more common or more frequently diagnosed common comorbid conditions. So these can include anxiety, which I referenced before, as well as depression. You may also find mood disorders, bipolar disorder. We see a lot of overlap with attention deficit hyperactive disorder, or ADHD. We also see a lot of obsessive compulsive disorder, and this can be related back to the routines, repetitive behaviors. We also see a lot of eating disorders as well, and all of those can be intertwined. So you can see how difficult it can become. Where do we find the impacts of our common comorbid conditions? So we see these in our key areas of functioning. We see these within social relationships. As Lee alluded to, these can become complex as our individuals navigate and move on to romantic relationships. We see these impacts in school. We see these impacts in work. So how does this look? What does some of the impairment look like? And with anxiety, so I'll break it down between anxiety and depression. So with anxiety, we are going to perhaps see more social skills deficits. It could be, for example, getting up and giving a presentation. The individual may be very nervous about that, may stammer, may say a word incorrectly, and thus their anxiety may grow. We also see an increase in repetitive behaviors, and this can be due to what Lee was talking about earlier as well, and just being able to regulate. We can often think of sometimes when we're taking a test, people that are shaking their leg or tapping their pencil. This can be thought of as a regulatory strategy to help that person channel and focus. And so you may see increases in that. Increase in sensory symptoms. You may be more in tune with your surroundings, and thus this can become quite impairing when you are focusing on a lot of things. We also see increases in the core ASD symptoms that Lee highlighted so beautifully. And of course, we see impacts on our school age youth. Some of these can be thought of as decreased school attendance, whether that be related to social difficulties, whether that be related to giving that presentation in class that day, whether it be that there's going to be a fire alarm drill at school today. We can also see decreases in family cohesion, and as well as decreases in academic performance. How might this look with depression? So we see increases in social withdrawal. Of course, there is a lot of isolation that could happen. We see decreased in quality of life in general. We can see increases in tantrums, meltdowns, and we can also see increased frequency of suicidal ideation, intent, and attempts. As well, again, as an increased parent strain, it can be difficult to kind of manage all of these things that are happening, not only for the individual, but also for the system at large. So let's talk a little bit about suicide. It is, of course, a growing concern. I think every day that we hear the loss of another life, it's impactful. It's impactful for the family, the friends, the professionals, everyone that is kind of included in that system with the individual. So we do know that suicide is now the 10th leading cause of death in all Americans. On average, there are about 130 suicide deaths a day. In 2019 alone, over 47,000 people were lost to suicide. And as I mentioned, this doesn't include the system as a whole. So we lost 47,000 people, and there are far many more that are impacted by the loss of those 47,000 people. From 2012 to 2018, the rate of suicide increased from 12.08 suicides per 100,000 to 14.23 suicides per 100,000. So we can see increases across the board. Veterans, people 65 years of age and older, Native Americans, Alaskan Natives, and people with mental health conditions have the highest rates of suicide. So what does this look like across populations? So breaking down some of these metrics. So in our folks with ASD or autism spectrum disorder, we are seeing about 23.55 deaths per 100,000, and this is based in 2021. And this equates to about 7.2% of the population has been estimated to make an attempt of suicide. This is higher than US veterans, people above the age of 65 years and older, and Native Americans. And so the average American, as I mentioned previously, has a rate of 14.23 suicides per 100,000. Looking at veterans, so this is 22.6 deaths per 100,000, which equated to about 5,185 deaths in the year of 2018. And it equates down to 2% of the population has been estimated to make a suicide attempt. Looking at our Native American or our American Indian Alaskan Native populations, we're seeing a rate of about 22.1 suicides per 100,000. Again, breaking down to 15.5% of the population has been estimated to make a suicide attempt. And last, looking at those who are 65 years of age and older, we're seeing about 17.36 deaths per 100,000. And that was about 9,173 lives lost from age 65 years and older in 2019. And we've had 85,800, that was wrong, 0.3% of the population has been estimated to make a suicide attempt. So as you can see, kind of breaking down all of these different populations, you can see that not only are the rates of prevalence increasing, but we're also seeing very high markers for our autism spectrum disorder population. So what does some of the research say? So a study done in 2021 found that suicide attempt rates were 266.8 per 100,000 with people with autism spectrum. And this is compared to 63.4 incidents per 100,000 people without the disorder. So a very clear difference there. Another study done by Mays in 2013 found that out of a sample of children with autism spectrum disorder, 10.9% of the children had SI or suicidal ideation, 7.2% of the children had made attempts, and that there was a 28-fold increase in suicidal behavior compared to neurotypical children. Another study done in 2010 found that in a sample of 42 adults with autism spectrum, that 40% of that sample had considered committing suicide at some time in the past, and that 15% of participants had actually made at least one suicide attempt. And so we can see that these are staggering. The rates of suicide in ASD, and this is an important note, they may be underreported. And this is simply due to logistics, really. Can be due to people who complete suicides being undiagnosed, as well as the diagnoses not being included on death certificates and statistical databases. So what we may actually find being more representative, unfortunately, is that these numbers may be far higher than what can actually be reported. How does this look again in breaking it down in suicide and ASD? So we see that people diagnosed with ASD have over a 3-fold higher rate of suicide and suicide attempts compared to those without ASD. Our girls with autism spectrum are 4.41 times more likely to make a suicide attempt than their male counterparts. And overall, both people with both autism, they contemplate and they attempt suicide more frequently than the general population. So it is always important, whatever background we come from, whether it be mental health, education, being a parent, looking out for some of these markers, being sure to assess, asking questions, asking follow-up questions. As you can see, this is really impactful, and this number continues to grow. So just looking at it in a graphical representation, we can see our individuals with ASD are notated in red, and the general population is notated in blue. And so for thoughts of suicide, we can see that people with ASD were about 66% had thoughts of suicide, compared to the general population, which represents about 17% of those had thoughts of suicide. Looking at actual suicide attempts, we can see that 35% of people with ASD had made at least one suicide attempt, comparative to the general population, which is about 7% had made suicide attempts. So you can see, again, in a graphical form, these numbers are quite alarming and reason for more investigation and knowledge sharing. So what are some of the social concerns? So of course, difficulty interpreting nonverbal cues. We may see in our individuals that there is the tendency to react inappropriately to the nonverbal communication of others. And again, this can be for a variety of reasons. Perhaps the individual is misinterpreting the communication that is being shared. Perhaps it may be too quickly and the individual has not had enough time to process and react. There can be a tendency to invade other people's personal space, just wanting to be close to people, being able to hear them, the proclivity to dictate activities in joint play. So again, this concern of turn taking, engaging in joint play, perhaps playing with others that want to play a different game than the individual, and thus they may not want to partake in the activity that the individual has preferred and would prefer to continue engaging in. There can also be a tendency to hyperverbalize or perseverate on their specific interests. Again, we can see that in play and we can see that all over, perhaps in just speaking with others. We may not want to change that topic of communication because this individual is knowledgeable of that. And it may increase anxiety when we are talking about things that they're not necessarily all the knowledgeable about. How does this look emotionally? So we can see problem seeking or offering comfort in times of distress. Again, there may be misinterpretation, there may be difficulties with regulation, not knowing what they need in that moment in time. We can also see difficulty with spontaneously sharing enjoyment with others. Again, this goes back to play, this goes back to communication. We can also see difficulty identifying and or responding appropriately to one's own thoughts and feelings, in addition to those of others, right? So how are we regulating? What do I know that I may need in this moment? And what is the impact of that going to be? Is it going to help reduce some of the symptoms of anxiety? Could it perhaps increase? Could I be opening myself up to more sensory input instead of less? Am I being judgmental of my own thoughts and feelings? And sometimes this can be interpreted as insensitive, cold, and showing disregard for others. We may even see this in a therapeutic practice as someone being avoidant or resistant. And so there can be misinterpretations on both sides of the coin. So let's combine social and emotional. How does this look in some contexts? So we can see conflicts with family and teachers. We can also maybe even see this with coworkers, bosses, anyone in the social realm, really. We can also see rejection and or bullying by peers, social isolation. So when all of those things become too much, this can lead to isolation. This can lead to withdrawal from that peer group, from that work group, from that context in general. We can see impaired academic and vocational performance, as any of us may have experienced, right? We could have a lot going on and we may not have that time to study for the test. We may not know what is required for the assignment. It may even be executive functioning that doesn't allow us to work towards completing that academic or vocational aspect in time and on task. We can also see a significantly heightened propensity for affective disorders in adolescents. And all of these things can lead to limited prospects for independent living, college education, and adult employment. So again, really important to be able to effectively identify, diagnose, and allow intervention, supports, and services to take place so that we can only optimize the potential of all of our individuals. What are reasons for seeking treatment? I think this can be a very subjective question, and it can meet different people at different times. So often what we see in the ASD population is that people diagnosed with ASD, they're encountering difficulties in everyday living. Many of the things that we just highlighted, and this can make them vulnerable to a wide range of mental health conditions or concerns. So again, having difficulty with that emotional understanding, that social interaction, not only are they a hallmark of ASD, but they can also be prognostic indicators of different diagnoses of different mental health concerns. We are also looking at more likely to experience higher levels of anxiety. One can imagine when you are managing all of those things, thinking back to the graphical representation that Lee had, when one is managing all of those different counterparts of what makes them them, and there may be a deficit in one area, it can really lead to increases in anxiety on how to manage that, on how to make it through that, on how to mask through that. We also see individuals at a significant increased risk for depression. And we also know that individuals can experience significant anger management issues. This can again be rooted to communications, misunderstandings, misinterpretations, and inabilities to sometimes emotionally regulate. We have all experienced something where we'll explain something to someone, they don't quite get it the first time. We might rephrase, reiterate a second time. And if there's still a misunderstanding, sometimes some of us are very internal and can become angry with ourselves. And often there can also be outward anger if someone is not understanding what you're saying and you feel like you are clearly explaining it. So what does this look like? I think the grand question in the bottom is, are there less females with ASD? Or could there perhaps be a gender bias in how we're perceiving ASD? What can come into play with this? Diagnostic overshadowing. So comorbidities are usually late to be recognized and diagnosed. What are some ways that we can combat this? Simply provider and educator training, things that we are doing now, helping to share the word, helping our clinicians, our professionals in the community best know what indicators to look at, the diagnostic criteria, and how this could look as an interplay, which Cheryl is going to be going over shortly. The status of ASD in the DSM. As we know, it was previously diagnosed as separate disorders within the DSM, and until recently with the latest iteration of the DSM was all combined together to be one representative umbrella of ASD. Why is this a problem? Again, this can leave comorbid conditions to go untreated. We may focus on the most prevalent diagnosis in the moment, And this can sometimes be at a lack of intervention for the other ones, or simply recognizing how all of those things are coming together and impacting core ASD symptoms and vice versa. And again, with these prevalence of common comorbid conditions in individuals with ASD, these can often serve as a two-way street for exacerbating one or the other. As I mentioned, increasing these core ASD symptoms while also seeing increases in depression, social isolation, anxiety, OCD, ritualistic tendencies. So the coexistence of multiple disorders may make it difficult to recognize ASD in individuals exhibiting symptoms. A lot of times there is question of, is it ASD? Is it more of the anxiety? And how do we necessarily be able to parse that out and work effectively with the individual? Females with ASD have a tendency towards more internalizing symptoms compared to this externalizing symptoms that we often see with our males with ASD. Females are also likely to be captured under labels that are more familiar, to providers and the female population. So perhaps we know that in certain diagnoses that more females likely get this diagnosis. And so perhaps that may feel more comfortable to providers to stick with that diagnosis as opposed to kind of going out and giving a diagnosis that has less merit in that particular population. We also see, again, camouflaging, and we know this can most definitely impact our rates of anxiety and our depression, particularly in our females. So I'm going to toss it over to Cheryl now. And so as I mentioned, we are seeing this interplay. And so how does this look? So Cheryl, help us break it down and see how this interplay comes together between mental health and ASD.
Thank you so much, Alexandria. Before I get started on my section, I wanted to thank you all for participating in this webinar. And to obtain a certificate of completion, you must fill out the form at the certificate of completion link provided to you in the email for this training. Please write down this code that I'm going to give you because you will need it for your CEU. The code is ACL2022. Again, that code is ACL2022. Okay, so to get started on talking about how all this looks together. So I'm going to be talking about the interplay of mental health and ASD, and also to, just to kind of give an overview of why this is so important to understand how these two systems come together. Is that Asd Core Challenges can lead to mental health conditions, as well as a misdiagnosis of a mental health condition. And also mental health conditions can exacerbate Asd Core Challenges. Research has shown that females are oftentimes misdiagnosed with mental health disorders or conditions when they display symptoms that actually meet criteria for ASD. Females are often diagnosed with disorders such as social phobia, social anxiety, depression, borderline personality disorder, bipolar disorder, based on this atypical or complex presentation. Females with ASD have also been reported to have super high levels of co-occurring internalizing disorders, as Alexandria pointed out, of anxiety and depression. Females oftentimes report that they have been in mental health counseling or seeing a mental health professional for their ASD or for their anxiety or depression. And oftentimes that is the focus of the therapy on that anxiety or depression. And it isn't until many years later that they actually receive the ASD diagnosis. So I'm going to be talking about systems here, just so that, I can talk about each system and then talk about how they combine and how they look together. So when I use the word system, you can think about it as a component of this. I'm just using, or even a layer, I'm using the word system here, but it is crucial nonetheless, whichever term you choose. It's crucial to understand how all of these systems come into play so that we're more effective with our treatment, and just kind of bringing it together at the end when I will be doing a case study so that we can kind of look at how these complex systems present. So the most asked question I get as a clinician, and this is from both parents and other clinicians, is how do I know when it's a mental health condition? Is it just the ASD, or when do I even, assess or bring my child in to see a mental health professional? And the answer to that is you look at a person's baseline functioning level. So mental health can present in a person with ASD as an increase in their ASD core characteristics. So you want to think about assessing or going in for mental health being assessed, by a mental health professional when those core characteristics are above what the baseline is. So also, that there's three different systems within the system. Mental health can appear very typical in those with ASD, or it can appear as a increase in baseline, or it can occur or present as both atypical and typical symptoms. So individuals with ASD can exhibit what clinicians refer to as typical presentation, which would be sad or withdrawn, or drastic changes in mood, behavior, personality, as Alexandra was talking about, anger symptoms, oftentimes either internal or external. So it could also be sleeping habits are different, but then, it kind of also understanding that those typical core challenges of ASD can look like they've gotten worse. So it could be also aggression or increase in aggression, self-injury, or increase in self-injurious behavior, regression of previously learned skills, more of those calming behaviors like self-stimulation, self-calming, increase in behaviors, maybe that increase in a perseveration in area of interest, or even not being interested in a previous area of perseveration, meltdowns or increase in meltdowns, isolating or school refusal. So when you consider a mental health condition, you want to look at baseline emotional behavioral symptoms are above the individual's baseline, or the individual is exhibiting typical mental health symptoms, or they have that mixed presentation of both typical and atypical symptoms. And so any of those three you want to assess for mental health disorder. I do note here that take into consideration that mental health screenings and assessments are not ASD sensitive. So oftentimes, even when they're a self-report, self-assessment, it's really good for a clinician to go over the results just to be sure that the questions were understood and that the answers are understood as well. So the next system I'm going to be talking about is the Asd Core Challenges, or core characteristics and social cognitive challenges. We have to be aware of these. It's crucial to understand when treating mental health conditions. While I'm not going to go into depth with what these challenges are, as my colleagues both did an amazing job with that, I will just mention and there are the three components up here of the social cognitive, core problems, theory of mind, attending to and using social cues, receptive language pragmatics, understanding self, emotion, self-perception and regulation, sensory motor, and then some of the executive functioning that we see oftentimes, and also the triad of impairments, which are the DSM criteria, the social deficits, communication deficits, and restricted and repetitive behavior patterns. Might look like difficulty with conversation, difficulty understanding social rules, trouble understanding facial expressions, difficulty making and maintaining friends, restricted interest, that type of thing, even difficulties with hygiene or regulating emotions, particularly in adolescents and young adults, hypersensitivity to sounds or smells, difficulty adapting to increasing challenges. So on the next slide, I'm going to go into, so how do we assess these core challenges, or how do we know, because it's so important to have a baseline of where our clients or students, our children are with their core challenges. I have listed several assessments here. I'm not going to go into depth with all of them. There is a really great FAU card hosted a wonderful webinar it's rethinking the ratios, improving recognition of females with ASD by Dr. Loza and Balsamo, which they do a wonderful job of going in depth into assessment. So that is available on FAU Card's YouTube channel. I encourage you to watch it. It is really great and really helps you to understand the complexity here. But today I'm going to be talking about the social responsiveness, social responsiveness scale, the SRS-2. And this, I recommend using the SRS because it's such a wonderful tool to differentiate mental health from ASD core challenges. It also, it does a really wonderful job of letting the clinician know, what are the social deficits in social awareness, social cognition, social communication, social motivation, and restricted interests and repetitive behavior. The SRS-2 has gained a lot of support from and peer-reviewed studies that it is a wonderful tool for discriminating within the autism spectrum and between ASD and other disorders, making this test very highly useful for us as clinicians. And when the test indicates that autism isn't present, it often points to other conditions in which social impairment plays a role. So it gives a wonderful baseline of what these core challenges are. And I'll talk more about how this will be incorporated into a treatment plan in later slides. So understanding the systems, the next system is the gender differences that my colleagues have been talking about earlier in the presentation. And I like to think about it as a broader phenotype because it does a wonderful job of explaining and helping us understand females. But I think it also helps us understand that there's a lot of males that fall within this category as well. Our research suggests that, our recognition of autism and current methods of diagnoses are based on those stereotypes of autism as a male condition and stemming largely from that theory of the extreme male brain. And there's so many people, both female and male, that don't fit, that extreme male brain phenotype. So it's really exciting that research is now showing us that we can expand and that this allows us to recognize and catch and diagnose and treat both females and males. Certainly I think we can all agree it's very problematic overall to utilize the male model, since both females and males can exhibit characteristics that don't fit. And the broader phenotype, of course, takes into account that females typically present with more internalizing behaviors compared to the more typical externalizing behaviors seen in the male model. So while I won't be going into all the specific differences in females, because my colleagues again did such a wonderful job with pointing all those out, I do want to focus a little more closely on the masking behaviors that typically accompany this broader phenotype. So masking, what most often seen in females with ASD, can prevent clinicians from making that accurate diagnosis, which makes it so important for us to understand this. And it can also lead to autism burnout, which increases the risk of mental health conditions and suicidality, as Alexandra was pointing out earlier in the presentation. The numbers are so high. So this is really helpful and important for all of us to understand. So masking is the use of strategies to minimize or hide autistic traits, and is frequently described by those who use it in research as being mentally, physically, and emotional draining, requiring intensive concentration, self-control, and management of discomfort. So on the next slide, I'm going to talk a little bit more about the autistic burnout. And I think it's important to note here that most of us want to help our clients and students and children fit in. So, but that's not what this masking that I'm referring to, or we've all been referring to, is. So we all, want to help ease, make things a little bit easier for our children, students, and clients. But what masking is really, it's a constant state of anxiety, and it's fueled by that need to conform in all situations, as well as a heightened awareness of appraisal of others. And oftentimes that's where that anxiety, it looks like, and it is anxiety, but it causes anxiety, but oftentimes it's misdiagnosed in a therapy setting as just anxiety, not understanding that it's actually being caused by this autistic burnout. While masking in some situations can be helpful, having no break from this masking or actually losing your identity can be exhausting, and as I said earlier, it leads to those mental health challenges and suicidality, oftentimes to depression. And so it's a term referred to in research, particularly connected with females, but not solely. NIH-supported research by Dr. Raymaker and her team out of Portland State University have done a great amount of research in this area of masking and autism burnout. And they have realized the need to come up with more an unambiguous definition of autism burnout and better understanding of autism burnout implications and recommendations for females and males on the spectrum, as well as for families and clinicians. So it's important to understand autistic burnout because it can lead, again, to that increase in mental health conditions, and has a lot of overlap with depression. So it's so important to understand it in that respect as well. It also needs to be considered when treating for depression, which I will get into a little bit more in later slides. It's notable to mention that people on the autism spectrum have been talking about this autistic burnout for a very long time, and research is just starting to catch up with what they already knew. But it's, it's hopeful that we are where we are today. So a bit of good news, while we don't really have an assessment for autistic burnout right now, there is an assessment for that masking and camouflaging that causes the autistic burnout, and it's called the CAT-Q. And it's showing a great deal of promise, being referred in research to a robust, valid, and reliable self-report measure of social camouflaging behavior. And this is in ages 16 and up. So it's a free tool. It can be found on the internet. It was developed by a young woman who is on the spectrum. I highly recommend that clinicians consider reviewing the questions at least, even if you don't use it as a screening tool, because you can either incorporate some of these questions into an intake, or if you start to suspect this might be what's going on, or if a client with ASD is presenting with ASD with depression, this is something you can, incorporate some of these questions, or use the screening to understand, is this what is leading to the depression? So it is especially useful when screening or assessing for depression, since autism burnout can be misdiagnosed as depression as well. And it needs to be treated a little differently than depression. So that makes it also another very important reason. Some of the sample questions in this CAT-Q, I wanted to just briefly mention. When I am interacting with someone, I deliberately copy their body language or facial expressions. I monitor my body language or facial expressions so that I appear relaxed. I have developed a script to follow in social situations. I will repeat phrases that I've heard others say in the exact same way that I first heard them. So I adjust my body language or facial expressions so that I appear relaxed. In social situations, I feel like I'm pretending to be normal. So I did put up here that this CAT-Q is available at embraceautism.com. And, I do hope that you take the time to, again, if you don't use it as a screening, just review the questions and consider whether you want to incorporate some of that into screenings for mental health. So I put together a case study so that it would hopefully be a helpful way to understand how all these systems can combine, and so that you can start to understand how you might conceptualize a treatment plan when all these systems are at work. So this is Bella, and she's age 16. I'm going to go ahead and read the case study and kind of highlight which systems are at work in this little brief paragraph. Bella has felt she was different from her fellow students starting in elementary school. A sense of being different and not fitting in made her feel vulnerable. Peers teased her, ignored her, and did not include her in activities she wished to participate in. She reports most of her classmates are unaware she has ASD and that she works hard to hide it from them. So there's the broader phenotype, or that we want to be aware of, and the masking and the burnout red flags. She is frequently exhausted after school because it takes a great deal of energy to fit in. Again, those red flags up for that phenotype and that masking and camouflaging. She first started feeling depressed when she started high school 2 years ago, though it quickly or recently worsened. So our red flags go up for, do we assess for depression? Parents report that Bella has always displayed a quick temper. However, she has recently started having explosive anger outbursts and refuses to do anything with family, seems sad all the time, no longer interested in her art, which was her special area of interest. And that over the past 2 months, she has started isolating in her room most of the time. So that gives us a couple things there. That gives us not only red flags for the depression, but also an increase in her baseline ASD characteristics. And pointing out that, like, her special area of interest, she no longer has that interest. Parent added that Bella has always enjoyed alone time in her room, though is now refusing to leave her room to eat meals with family. So again, raising that baseline. Okay, so the problem list for Bella: depressed mood, severe social anxiety, social withdrawal, extreme irritability, and the anger outbursts. So the diagnoses after the screenings and assessments, we know she has autism spectrum disorder. Major depressive disorder, she did meet criteria for that. and social anxiety disorder as well. So now I'm talking about how do you bring all this together? How do you conceptualize it? And, you know, I think about it as how do we treat the mental health conditions in the context of the ASD so we're most successful in improving things for Bella. So because of the complexity of these systems and the components necessary for formulating a treatment plan who presents both with ASD and mental health needs, it's really helpful to have an organizational mechanism that helps us bring it all together and to help us begin to hypothesize and determine appropriate treatment. And it doesn't have to be any one type of tool. It's whatever would be, you know, most helpful for all of you that would allow you to, you know, take all those systems that it's the complexity and just pull it all together. And what is this going to look like, you know, as a actual treatment plan for Bella? So bringing it all together, that case conceptualization for Bella. So the depression, under depression, here I have, she did meet DSM-5 criteria. And again, I point out here also assess for suicidal ideation. We know the numbers are super high, so always important to make sure we do that. And in Bella's case, she did not have any suicidal ideation. The core ASD challenges, the social cognitive, that's where, you know, I did the SRS, I have her baseline. So I know, you know, she has a poor understanding and expression of her own mental states and needs, and poor understanding of the mental states and needs of others. And she has difficulty regulating emotion. And then I also combine with that other system, that gender broader phenotype. And that's where the masking is going to come in. So the masking that continually during the school day, leading to increased feelings of depression, anger, exhaustion, and burnout. I put suicidal ideation in there again, because it's just really important that, you know, when we know there's masking behaviors going on, we also, you know we should assess. So we're kind of looking at a fuller picture of the depression. Moving over to the social anxiety side, she did meet DSM-5 criteria for social anxiety disorder. Again, the core ASD challenges and social cognitive challenges, social confusion, unpredictability of social encounters, theory mind, difficulty with perspective taking, and then the broader phenotype or the female phenotype, that masking again falls under there, increasing her anxiety, trying to keep her diagnosis a secret, trying to avoid being bullied as well, and teased. Down below, I have all the resulting symptoms and behaviors that stem from both the depression and the social anxiety, the withdrawal, the extreme irritability, sadness, anger outbursts, and the isolating and exhaustion, and also the loss of interest in her area previously enjoyed interests. So how does all this look like when we take all these symptoms and put them together, we conceptualize everything, and now we're treatment planning. So for Bella, her treatment plan, and I broke it into 3 categories so you can see that there's very specific tools that we use for each piece, and they're very different from each other. So really to help Bella, to provide the best support to Bella, we really have to include all these systems. So under depression, the core ASD and social cognitive challenges, those are the SRS or the ASD specific. We want to focus on those. We want to teach self-awareness. We want to teach emotions. We want to teach emotion regulation skills, recognition of emotions of others, calming strategies, breaks, decompressing, Looking at under that depression category and the gender considerations and the Brado phenotype, we want to help her to have time without having to mask, like schedule time where she's, can take that mask off and she can, give herself a break and be herself. We want to do energy accounting, boundaries, learning how to say no when she knows that she's reached her limit. Self-care strategies, setting realistic expectations, breaks, paying attention to her body. Under the mental health for depression, that's when you see the more typical mental health treatment like CBT, working on schemas of self and others in the world, the emotion charts, SUD scales, adapted dialectical behavior therapy, self-regulation techniques, and to go down over to social anxiety, breaking it into those 3 areas as well. So social anxiety, what are we looking at for these ASD core challenges and social cognitive challenges? We want to increase confidence and confidence in social situations. We want to teach perspective taking skills, reading nonverbal cues of others, teaching assertive communication. Under the gender Brado phenotype is the confidence building skills and tools, teaching Bella how to handle teasing and bullying and in order to decrease the need for her to mask all the time. And of course, with teasing and bullying, adding to the depression most likely and to the anxiety. And then under mental health, again, the very typical mental health type tools or techniques, calming techniques, mindfulness, deep breathing, progressive muscle relaxation, exposure and response prevention for the anxiety. These are all in adapted ways, but they work really well for individuals on the spectrum. And again, the CBT, which is a really strong evidence-based for individuals on the spectrum. So that is our presentation. We did put up some future directions here where we feel that, we could research certainly is working on many of these, but we could all benefit from more focus on universal definition of autism burnout, an assessment for autistic burnout, treatment recommendations for individuals with ASD, their families and clinicians, more ASD sensitive mental health assessments. As I mentioned, our ASD, our mental health assessments are not ASD sensitive right now. Developing guidance for adapting commonly used therapeutic tools, curriculum for college courses and in the fields of mental health, social work and education, medicine, nursing. Many of us, myself included, when I graduated from my graduate program, I didn't come out with having training and information education in the area of mental health and how you approach mental health in an individual with ASD. So definitely focus on that, and certification courses for all of us that are already in the field and we could benefit from this type, and part of why we're doing this training today is to fill that need because we know there's a big void in information out there on both these ASD and mental health. It's usually so siloed. And developing resources and studies on masking in younger individuals on the spectrum is really important. We put together some resources we hope will be helpful to you. There's some great books out there that focus on women and children and females with autism spectrum disorder and mental health. Tony Atwood's videos on YouTube. He does a lot of work in that area and wonderful videos on Asperger's and girls and comorbid mental health. Sarah Hendricks, an adult who is on the spectrum and is also a mental health professional. She's amazing and does some wonderful videos as well. We hope that you can use some of these to help, beyond the presentation to gain more information. Resources on social skills challenges here, peers, wonderful curriculum, and definitely for clinicians to even incorporate some of this into individual sessions with clients, particularly when there's, focus on relationship building, and also for skills to help individuals deal with teasing and bullying. Wonderful curriculum on that in the peers programs. And here's some more resources for therapy, including, CBT and DBT, and just, really helpful information, wonderful books on depression too. Hope that you'll take a look at some of these. More resources online and in the community. And of course, please reach out to CARD. We can, CARD can help you navigate this whole process and put together resources and let you know more about what is being done by CARD and where you can become involved. And a couple more resources here. We have several references, very interesting references that we used here, and you might even benefit from going through the reference part of this and looking at some of these research material and articles. They're very helpful. So I wanted to first thank Alexandria and Alex. It's been wonderful going through this process with both of you, and certainly a huge honor presenting with both of you. And I wanted to thank everybody for joining us, and I really hope that this was beneficial for you.
Yes, thank you so much, everyone, for joining us.